Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today I'm going to be talking about acute renal failure. This is based on a request that was made to me. So I hope the person who requested it actually watches it, and I hope the rest of you enjoy it as well. So let's get started. Hello, Clinic Review family. It's so good to see you again. I got my tooth fixed. Yes, I have caps on my front teeth. They're temporary caps. They have to make the permanent ones. So I feel like I'm lisping all the time. So I'll try not to lisp too much for you. You know that this channel is a part of the Greater Clinic Review organization, of which Mark Klimek himself started over 40 years ago. He's mostly retired, but you can still do the online on-demand Clinic Review, which is the full 21 plus hour Nclex review that he does online. It's an excellent one. We don't cover the same information on the YouTube channel, and I highly recommend it. So we also have a streaming service through Clinic Reviews, and we have small group tutoring. And the small group tutoring is 4 small group tutoring sessions. I do 2 of them. Pete Savard does 2 of them. We do next gen questions, and we do other things. So, all right. So that got business out of the way. So I'm talking about acute renal failure. Chronic renal failure is similar to acute renal failure, except that the damage is permanent to the glomerulus and to the nephron. So let me just talk a little bit about acute renal failure first. So you know the purpose of the kidneys is to filter waste. It also gets rid of water and electrolytes. It manages the electrolyte balance in our body. It manages the water balance in our body, and it excretes waste. So when someone has a problem with their kidneys, you know there's going to be fluid and electrolyte imbalance as well as waste buildup. Now, why do people die from kidney failure? So there's a couple reasons why people die from kidney failure, but it's not usually just because waste builds up. A lot of the reasons people die from kidney failure is electrolyte imbalance. So think about the potassium's not being excreted. It builds up in your body. That can actually stop your heart. It can cause a chronic renal failure, can cause low hemoglobin because it's the erythropoietin that's secreted by the kidneys that stimulates the production of red blood cells so they can become anemic. And then ultimately people die from metabolic acidosis. So when the severe kidney disease, the kidneys can no longer get rid of the hydrogen ions. They can't get rid of the acid load in the body. The person goes into a metabolic acidosis, and their heart basically stops. They stop breathing, their heart stops. Remember the phrase, as the pH goes, so goes my patient. So as the pH goes, so goes my patient. So if the pH is going down, your patient is going down, right? That's why we care so much about acidosis. So that's something that they end up dying from. So how can someone go into an acute kidney failure? Well, there's really 3 ways. It's called pre-renal, intrarenal, or post-renal. And that's not necessarily something you have to know for Nclex, but if you are getting ready to take a test as it relates to acute renal failure, maybe this is something you want to know. So let me just talk about pre-renal, intrarenal, and post-renal. So it's either a problem which is pre-renal. So pre-renal means there's not enough water or blood getting to the kidneys. So anything that causes renal hypoperfusion. So what can cause renal hypoperfusion? Well, shock can certainly cause renal hypoperfusion. So dehydration can cause renal hyperperfusion. Heart failure can cause renal hypoperfusion. So anything that decreases cardiac output. So if the cardiac output is decreased with heart failure, the person becomes dehydrated or they go into shock. So these are pre-renal causes. That's why it's not that unusual for someone who's admitted to the hospital in heart failure. They also have an acute kidney problem, right? That's very common because they're not perfusing their kidneys. 25% of cardiac output goes to the kidneys. So if you decrease cardiac output, you decrease kidney perfusion. So that's pre-renal. That's a pre-renal cause, which is a very, very common cause, by the way. Very common for our patients to come in dehydrated or heart failure, and they have acute kidney injury. Then there's intrarenal, where maybe they take a medication that actually causes damage to the glomerulus. It causes problems. Maybe it causes inflammation. Maybe they overdo it with their workout and they end up having too much waste release from muscle breakdown. They end up clogging up their nephrons and they're not filtering anything. That's all intrarenal within the kidneys, right? And so what you have to do with that is you have to either sometimes you just have to wait. Sometimes you have to do resting and waiting while that thing kind of takes care of itself. Sometimes you can give things to decrease the inflammation. Sometimes you literally have to rest. Israel's just staring at me. Sometimes if it's too much of a workout, and they broke down too much muscle, they're on bed rest for a while. So it really just depends, right? That's intrarenal. If they took a medication that caused damage to the kidneys, probably we're going to have to do some fluids and try to get that stuff cleaned out, and probably do some steroids to try to reduce any of the inflammation that might be in there, right? And you just kind of have to wait it out. So that's pre-renal, intrarenal, and then post-renal is something that causes backup of the urine. And when you cause backup, it increases the pressure and you can't have any filtration. So what can cause backup? Well, it could be kidney stones. It could be a pretty serious bladder infection, right? It's anything that prevents excretion of the urine from out the body. That's post-renal. So those are some things that can cause acute kidney failure. I don't really think you're going to be tested specifically on the causes, but you just kind of conceptually need to know the difference between acute and chronic kidney failure. Is acute because it's like either a dehydration problem. We take care of the dehydration. They're fine. If they had too heavy of a workout, and so much of the muscle breakdown is getting clogged in the kidneys. It's called rhabdomyolysis. Then we're going to have to stop the workout. They're going to have to rest and hydrate and so forth, right? And so it's kind of a waited out. And if it's a post-renal where they have a big old kidney stone or something like that, we're going to have to treat the kidney stone and then kind of let that heal up. So that's why it's acute versus chronic. It's chronic disease, chronic hypertension, diabetes. These are things that cause permanent damage to the glomerulus and result in changes that they can't be reversed. Okay. One of the things that you notice is you notice obviously changes in the urine. So one of the things just kind of conceptually you need to understand is that the glomerulus is the point where everything is filtered, right? And literally all the blood in your body is filtered. All the serum in your body is filtered through the kidneys, and then it's reabsorbed in various places in the nephron. So the descending loop, the ascending loop, the distal convoluted tubule, blah, 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 all that stuff, that has to reabsorb water. So everything is filtered and then has to be reabsorbed. And then whatever's not reabsorbed is actually excreted. And it also filters particles that are small enough to get across the alveolar capillary membrane. So you have the alveoli and you have the capillary, and anything that can cross that, and it doesn't cross through the cells, it crosses in between the cells. So whatever's filtered has to be small enough to fit between the cells. So as damage occurs to that glomerulus, you start to have bigger openings between those cells, and you can start to see bigger things being filtered. That's why with kidney failure, whether it's acute or chronic, you see those bigger things in the urine, like proteins, red blood cells, white blood cells. Those are big particles that normally are not filtered, or they're filtered in very, very small amounts. And you start to see those things in the urinalysis when there's damage to the glomerulus. Okay. Hope that made sense. All right. Let's go ahead and do some questions to see if you understand these things, and I'll do some additional teaching as we go through. We've got quite a few questions, so this may take a little while. Which client is at the highest risk for developing acute renal failure? A 25-year-old client with asthma using an albuterol inhaler, a 50-year-old client with heart failure, a 32-year-old client recovering from an uncomplicated appendectomy, or a 70-year-old client with pneumonia. So we talked about what are the risk factors for acute renal failure. So pre-renal is dehydration or poor perfusion. Intrarenal is if they did a heavy workout or if they used a medication that caused damage. And then post-renal if they have a urinary tract infection or they have a renal stone. And the only one here that is any of those things that put them at risk for pre, intra, or post-renal problems is the heart failure one. And so that's what we choose. All right. A nurse is assessing a client with suspected acute renal failure. Which clinical manifestation should the nurse expect? So, polyuria, decreased blood pressure, hypercalcemia, and hyperkalemia. So, what I'm going to do is I'm going to make sure that I don't overthink this. I'm going to relate each one of these symptoms back to acute renal failure. So, polyuria is a clinical manifestation of acute renal failure. Well, that's false. It's actually low urine output. Polyuria, once they're recovering, there is a diuresis phase, but that's later. So, no, polyuria is not a clinical manifestation of acute renal failure. Decreased blood pressure is a clinical manifestation of acute renal failure. It's not an acute. It's not a manifestation of acute renal failure. It could happen if they're getting dialysis, but this isn't dialysis. It's acute renal failure. It could happen if they're dehydrated, if dehydration is the cause of renal failure, but it doesn't say that. So I'm just looking for a classic symptom of clinical manifestation of acute renal failure, and decreased blood pressure is not a classic symptom of acute renal failure. Hypercalcemia is a clinical manifestation of acute renal failure. That's actually not true. They do have a calcium imbalance, but it has more to do with vitamin D. So the kidneys do something with vitamin D, which allows the calcium to be absorbed. And if the kidneys aren't doing whatever they're supposed to do with vitamin D, then the calcium's not absorbed and they lose it. So actually, it's hypocalcemia is a manifestation of acute renal failure. Hyperkalemia is a clinical manifestation. Yes, that's actually true. If you're wondering, how do they decide when to do dialysis for someone with renal failure? One of the ways they decide is when the potassium starts to go up, because they're not able to excrete the potassium like they should be able to. So hyperkalemia is a clinical manifestation. A nurse is caring for a client with acute renal failure due to dehydration. Okay, so this time they tell me dehydration is the reason, which is the priority nursing intervention. So remember, dehydration is pre-renal. Encourage oral fluid intake. That sounds fine. Administer prescribed IV fluids. That sounds good. Insert a urinary catheter. Maybe, but it doesn't seem like it's a priority. I mean, they're dehydrated. So I might put in a urinary catheter to measure INO, but I don't have to. There's other ways to measure it. Administer furosemide. So furosemide is commonly given with renal failure, but not when they're dehydrated. That doesn't make sense. So if I'm just using my common sense, D doesn't make any sense. C doesn't seem like a priority. Remember, priority means if you can only do one thing, which one thing do you want to do? If I choose urinary catheter, that means I'm not going to encourage fluids, and I've got to give fluids, like they're dehydrated. So I'm crossing off C. Now, I have to pick between oral or IV. Remember, it's a priority, which means I can only do one. So if I can only do one, would I rather do oral or IV? Well, I would rather do IV. That just makes more sense to me. Use clinical reasoning and common sense, y'all. And I think everybody can get that one. A client with acute renal failure has a potassium level of 6.5. Which action should be assigned to the first-year student nurse? Administer sodium polystyrene, K-exalate, assess the cardiac rhythm, administer oral potassium, administer calcium gluconate IV. All right. So we have a potassium of 6.5. So they are hypercalcemic. They're hyperkalemic. So which one of these is appropriate to give when they're hyperkalemic? Well, A is, because A promotes the excretion of potassium through the gut in the stool. So I like A. Assess the cardiac rhythm. Well, I know people who are hyperkalemic are prone to dysrhythmia, so I like that one. Administer oral potassium. Okay, that's out. C is completely out. That's not even a good option. Administer calcium gluconate IV. So giving calcium gluconate is appropriate. It actually, I'm not an expert at this, but if you read the book, it'll tell you that it stabilizes the cardiac cells, so they're less likely to go into a cardiac dysrhythmia, experience cardiac dysrhythmia. So what does that mean by stabilize the cell? I mean, I sort of makes sense to me. I do understand what it's talking about. It's decreasing the probability that the cardiac cell is going to spontaneously depolarize, like all on its own. So they're not going to have a bunch of PVCs or going to VTAC or anything like that. Like, I get that. That's what calcium gluconate does. So A, B, and D are all fine. So, but there's a second part of this, and that's the first-year student nurse. Now, one thing I haven't talked with you about is kind of this hierarchy of actions that we do as RNs. So the National Council of State Boards of Nursing views the hierarchy of things RNs do. The top is teaching. So they believe teaching is the most complicated thing that we do. And the least complicated thing that we do is skills. So at the top of that complexity level is teaching. They consider teaching to be the most complex thing that we do. And then is care planning. They consider that to be very complex because we have to develop a plan of care for the patient. And that requires education and knowledge and ability to assess. So we don't delegate those things to the LPN, and we never delegate an assessment because assessing things is considered to be require more understanding of the disease process and how it manifests and so forth. So we never delegate. We also never delegate IV push meds because there's considered to be a high safety risk associated with IV push meds. So those 4 things we never delegate, but everything else we can delegate, right? Everything else we can delegate to an LPN. And so this doesn't say LPN, I understand that, but this is a student nurse. So really theoretically, you could delegate anything to a student nurse that you can delegate to the RN as long as you're supervising them. So I would look at this and say, okay, let's talk about someone who's pretty inexperienced, their first year. I don't know what their school lets them do. I don't know what the hospital policies are. So I can't make a decision based on what my school lets me do. I can't make a decision based on what my hospital policy is. I have to think conceptually and I have to think hierarchy, right? A first-year student nurse would probably be doing something lower on that hierarchy. So administering sodium polystyrene or KX-late, that's a PO med. So PO meds, that's lower, right? That's kind of skill-based. I mean, you have to know some pharmacology, but that's definitely down lower. That's not IV push. That's not care planning. That's not assessing. That's not teaching. So I like A, assess the cardiac rhythm. It says assess, and assess is higher level. That requires a lot of critical thinking. So I'm like, I don't know about that. Administer oral potassium. If potassium was an appropriate intervention, I could pick that one, but I had to cross it off because that's not appropriate and they're hyperkalemic. And then administer calcium gluconate IV. Well, that's high level as well. So which of these is appropriate and on the lower level of skill based on this hierarchy? Well, the only one that is both appropriate and lower level on the skill hierarchy is A. So I just walked you through a question that has a higher level of complexity. If you're like, gosh, I didn't get that one at all. You need to think about what I talked about because I'm teaching you principles that are important to remember when you talk about delegation. Okay, the National Council does consider there to be a hierarchy of skills that RNs do, and we never delegate those things at the top, but the things at the bottom can be delegated. You can even delegate them to a student nurse. A nurse, the nurse knows that which lab value is most indicative of acute renal failure: decreased hematocrit, increased liver enzymes, elevated serum creatinine, elevated white blood cell count. So I actually would expect A and C because if the hemoglobin drops, like if the red blood cells drop, the hemoglobin drops, the hematocrit would drop along with it. However, which is most indicative of acute renal failure, you may not have for acute, you may not see that drop in hemoglobin hematocrit if it's just a short acute episode. But I would see an elevated serum creatinine. That's a waste product that is almost completely secreted or excreted through the kidneys. And if your kidneys aren't working right, then you're not going to excrete it, sorry. Which dietary recommendation is most appropriate for a client in the oliguric phase of acute renal failure? High protein, low carb, low protein, high sodium, low carb, high fat. So do you remember I told you that when you have glomerular damage, the kidney is more likely to filter larger particles? And I said protein is one of those larger particles that is filtered. So that's the reason during the oliguric phase, oliguric means low urine output phase of the acute renal failure, we don't want a lot of protein. So I want to get rid of the high protein options. So A is a high protein option and C is a high protein option. So I'm crossing those off because that's not appropriate. You can actually do more damage to the glomerulus if you do high protein during the oliguric phase. So I have to pick between high carb, low protein, which I like because they still need to get calories, or low carb, high fat. Well, I don't like the idea of high fat. Do I ever do a high fat diet? I don't know. I can't think of one. Maybe I'm not thinking clearly, but B is the correct answer. A client is in the diuretic phase of acute renal failure. What's the priority nursing intervention? So this tells you they're starting to come out of it. They're starting to heal. Remember, this is an acute renal failure, not a chronic renal failure. So they're starting to heal whatever caused the problem, whether it was dehydration, whether it was an acute injury to the glomerulus. whether it was a kidney stone, they're starting to heal, things are coming together, and they're starting to make urine again. So what do I want to do here? Administer diuretics? No, they're already diuresing all on their own. Restrict fluid intake? No, they're diuresing. We don't want to dehydrate them. Encourage high protein intake? That's not really a good idea when they're in an acute renal failure, even when they're in the diuretic phase. Strict intake and output. All right, I like that. Strict intake and output doesn't say we're limiting anything. It just means we're measuring everything that goes in and comes out, because we want to make sure that what goes in and comes out is relatively balanced, that they're not getting too dehydrated, that they're getting enough fluids, and so forth. Okay, so D is the correct answer. Which of the following medications should the nurse question in a client with acute renal failure? Metformin, acetaminophen, furosemide, calcium carbonate. So which one can cause kidney damage? Well, not calcium carbonate. That one's okay. Furosemide is okay. So does acetaminophen cause kidney damage? It doesn't. It causes liver damage. So that one's not a question. Metformin, that's that type 2 diabetic medication that can cause problems with the kidneys. So they should not be taking metformin when they're in acute renal failure, just like they should hold off on their metformin for a few days before they go for a test, any kind of diagnostic test with dye, like iodine dye. They're supposed to be off their metformin for a few days because you want to make sure the kidneys can filter out all that iodine. You don't want to cause any problems. The other medication that should be questioned with any kind of renal failure are nonsteroidal anti-inflammatories. Those can cause kidney problems. And the other one are ACE inhibitors. Those are blood pressure meds. They end in pril, like lisinopril, enalapril. Prils are ACE inhibitors. So metformin, ACE inhibitors, and nonsteroidals are all contraindicated with kidney problems. A nurse is caring for a client with acute renal failure who's receiving peritoneal dialysis. Which complication is most concerning? So if you don't know what peritoneal dialysis is at all, I suggest you Google it. They actually put a tube right into the peritoneal area, and they put what's called dialysate. It's like a huge bag. I don't know if it's 2 or 3 liters. They put dialysate into the peritoneal space so that they get very, very big. Their abdomen gets very big. And the lining of the peritoneum acts almost as that glomerulus, so it filters through there. So they actually put the dialysate in their abdomen, in their peritoneal space when they go to bed at night, and they leave it in all night. And they get up in the morning and they hook the bag back up to the tube, and it drains out into the bag. They leave the bag sitting on the floor. They let it drain out into the tube, and they get rid of that, and then they go on about their day. So this is for people who just don't want to do hemodialysis, maybe because hemodialysis 3 times a week, it's 3 to 4 hours. Not everybody has the time for that. So they can, do it at night. The biggest risk is that peritoneal space is going to get infected. So it requires high levels of sterile technique in attaching the bag, reattaching the bag, and covering the area. Like, you have to be very, very careful because they're at very high risk for peritonitis. And that tube stays in all the time. It's not like they stick the tube in and take it out. I mean, the tube is in there all the time. Then they just have to connect it to the solute or the dialysate at night, and they drain it in by gravity, and they drain it out by gravity in the morning. All right. The biggest problem is infection. So knowing that, which complication is most concerning? Cloudy peritoneal effluent, mild abdominal discomfort, bradycardia, or clear peritoneal effluent. So I'm good with clear. Remember, I don't know if I've said this before, but clear is good, cloudy is bad. That's just sort of general principle. Clear is good, cloudy is bad. So clear is good. So I'm going to cross that off. So that means A is a problem. And another thing, when you have opposite answers on an Nclex question, it's a single choice question. You have opposite answers. One of them is probably right. I mean, if you're just purely guessing and you have opposite answers, one of them is probably the right answer. So I do have opposite. So I'm like, I bet it's A, because I know clear is fine. But let's think about mild abdominal discomfort. Mild abdominal, I mean, that's expected. You're putting multiple liters of fluid in your peritoneal space. That makes sense to me. Bradycardia. Bradycardia doesn't tell me how slow it is. I don't know. Would I expect that? That is concerning if they're bradycardic, but it's even more, what is more likely to kill them? Peritonitis or bradycardia? Peritonitis is more likely to kill them. So I'm more concerned about the cloudy peritoneal effluent. A client undergoing peritoneal dialysis develops cloudy dialysate effluent along with abdominal pain and cramping after receiving orders from the healthcare provider, which is the priority intervention. Abdominal ultrasound, administer prescribed antibiotics, surgical consult for hemodialysis catheter placement, or increase the dwell time of dialysis fluid. Okay, so if they have cloudy dialysate, it doesn't make sense that we'd increase the dwell time of the dialysis fluid, so I'm going to cross that one off. So the others all seem reasonable. Now, this is one patient in the question. We think about prioritization. This is one patient in the question, and symptoms are in the question, and then we have orders or interventions in the answers. So when they say, here's the patient's symptoms, which order is your priority, I always have to address the objective problem first. If you haven't watched any of my prioritization videos, you need to go back and watch those, where I teach this strategy. We call it the Maslow's strategy. Maslow's hierarchy tells us you have to address, it's a modified Maslow for this, but you have to address the objective problems first. So what's objective? Well, they have cloudy dialysate is objective. Everybody can see that. Abdominal pain, I'm concerned about it, but it is subjective. And cramping, again, subjective. So subjective, you address actually third. So first is always objective. Second is any safety issues. And third is subjective. Fourth is psych issues. So here we have cloudy dialysate. What's the most likely problem with cloudy dialysate? The most likely problem is an infection, right? Because clear is good, cloudy is bad. And they could develop a peritonitis, which can kill them, and it can kill them kind of quickly. So if I have to address the cloudy peritoneal dialysis first, which order addresses that? Well, the order that addresses that is the prescribed antibiotics, because it's the infection, it's the cloudy dialysate. So I have to do that one first. The others are probably important. I'm sure getting an abdominal ultrasound is important, but for the purposes of testing, I'm talking about strategies and rules for testing the Nclex. You got to do the antibiotic first. The nurse is providing discharge teaching for a client recovering from acute renal failure. So they're recovering. Okay, which statement indicates understanding? Okay, we're discharge teaching. All right, discharge teaching, recovering. I no longer need to monitor my blood pressure at home. I don't know. That doesn't seem like a good option. I can resume using over-the-counter pain relievers as needed. Remember, I told you non-steroidals can exacerbate kidney problems. It doesn't say non-steroidals, but I would be cautious to say they could use over-the-counter meds, especially pain relievers. I'd be like, you got to ask your doctor before you use an over-the-counter pain reliever. I will monitor my weight daily and report any sudden changes. That seems like a good idea. I will limit my fluid intake to 4 liters a day. Y'all, normal fluid intake is 2 to 3 liters a day. So why am I telling them 4 liters? There's no reason to tell her 4 liters. That's too much. So D is out. B is out. Well, let's see which statement indicates understanding. So I want the true statement. I want the good statement. So the only good one here that I know for sure is good is C. I mean, I don't know. Maybe they don't need to monitor their blood pressure, but definitely they need to monitor their weight. Remember, pick the answer you know is right, not the answer you're not sure about. The nurse is teaching a client on peritoneal dialysis about infection prevention. Which statement indicates further teaching? So I'm looking for the false statement. I will clean around the catheter site daily. That seems fine. I will wash my hands before touching the catheter. That seems good. I will monitor for redness or swelling at the site. That definitely seems fine. I can shower without covering the catheter site. That does not seem good. They actually need to cover the catheter site when they shower. Now you might say, well, what does that mean? Is that a dressing? Actually, it's not just a dressing. They're actually talking about protecting it from the shower. That's what they actually mean. They recommend, like, I don't know, saran wrap, a bag. I don't know what you'd use, but they do recommend covering it, not even letting the dressing get wet, because it does have a dressing over the entire thing. The nurse knows that pre-renal causes of acute renal failure include which of the following? Glomerular nephritis, that's intrarenal. Prolonged hypotension, that's pre-renal. Kidney stones, that's post-renal. Acute tubular necrosis, that's post-renal. So we're doing pre-renal, so prolonged hypotension is the right answer. A client with acute renal failure develops Kussmaul's respirations. What does this indicate? Metabolic acidosis, pulmonary edema, respiratory alkalosis, or hypokalemia. So Kussmals are related to metabolic acidosis. Just remember that it's always Kussmals. Remember Mac Kussmal, MAC, Mac Kussmal. MAC stands for metabolic acidosis. Okay, Mac Kussmal, metabolic acidosis. Why do they go into metabolic acidosis? Well, I told you that at the kind of nearing the end of a chronic renal failure or even acute renal failure, if it's really severe, they fail to get rid of a lot of the acid load, and it can throw them into metabolic acidosis. So Kussmals is associated with that. All right, well, that's it. I'm done. That's the end of that one. So I hope that was helpful. I don't mind having you. I actually like it when you guys ask for specific things. Sometimes you ask for something that I've already done a video on, but some of the videos are starting to get a couple years old. So, if you're like, I want you to do this one again, even if I've done it already, I may go ahead and do it, start to update some of the videos. But I appreciate you being a part of the Clinic Review family. You guys are awesome. You're the best YouTube audience in the entire world. I appreciate you being here with us. And good luck on your Nclex and any standardized tests you might be taking. Take care.